Okay.
Um, I'm sorry. I know this is like the worst. I really wish they would figure out a way to um, make this easier to navigate. But on this one, I just had a question. I've seen it a few times. They say tilt test is positive. Do you mind just explaining what that is so I can like use that as like or just like know what it is?
Let's see. Transaction entry at the right of the midline and extending into the myometrium. There's a fluid in the cul-de-sac. No adenonexal mass was the most likely diagnosis. Okay, so let's figure out what a tilt test is because I'm not actually 100% sure, but let me tilt test.
Because I feel like I usually see it on like orthostatic hypotension or something kind of like that. But
Oh yeah, it's like syncope. It seems like I didn't know in what context because usually, like you said, you don't see it in the OB realm. But
yeah,
let's. Oh, I mean, I didn't read the whole thing, but let's read the whole thing. So diagnosis.
yeah, it's like an ectopic pregnancy.
Okay, right lower quadrant pain, vaginal spotting, pain with sexual intercourse, no history of illness, and then waiting to be examined because she has an onset of dizziness. That's the thing that I mean, I didn't scan over. She's tachycardic a little bit. Her blood pressure is low. Uterus is, 10 weeks gestation, tender, and tilt test is positive, meaning, that just shows you that, practically, right, she has orthostatic hypotension too, right? Meaning if she gets up too fast, she's already hypotensive, and so not enough blood flow, so she can pass out, right? Or get
Okay.
lightheaded. That's practically what it means. And then transvaginal ultrasound shows intrauterine gestational sac to the right of midline and extending into the myometrium. So usually, as you know, in OB, right, the ideal place is going to be kind of, let me see if I can draw here.
Like in the middle of the
Yeah,
uterus.
in the middle up here, right? Kind of
Yeah.
weird. So you know that it's, lateralized to one side, then something weird is going on. So maybe you have, kind of a bicorniculate uterus or something like that, right? Is something that you might be thinking about, right? Because it should be midline. And then, right, it extends into the myometrium, which is not per se normal, right? There's a fluid filled cul-de-sac and no adrenal masses. So yeah, so the best thing, right? So ampullary pregnancy is intrauterine, it can't be that. Complete abortion, right? Can't be that, right? Because she's not having an abortion. Incomplete abortion, not really. Inevitable abortion, it doesn't talk about kind
They
of,
don't give us a like a cervical finding, so
exactly. And then threatened abortion. I mean, threatened abortion has a very specific guideline, right? So let's kind of read what they say about threatened
it's like
abortion.
bleeding with a closed
Yep, it's
cervix.
usually without an open cervical os and the loss of products of conception, right? May progress as spontaneous or it may self-resolve without fetal risk. Not explain the hemodynamic stable immobility, right? Because she shouldn't lose that much blood that she's hypotensive,
Yeah.
right? So yeah, so tilt test just means that, it just further confirms why she's dizzy or lightheaded, right?
Okay.
That's all.
The next one is number 16. Okay, so this is like a 4-year-old boy with joint pain. And okay, I was like working under the assumption this was like sickle cell, but he actually has hemophilia 8. So I was wondering if we could just kind of talk about what I should have picked up in the stem to kind of point me towards that. And like heme is definitely a weak point. I know I say that about everything, but heme is a weak point. So we could just talk about this.
Sure. So just kind of starting 4-year-old, so pediatric kid, it's a boy,
Yeah.
that's important too. Emergency department, so it's more an acute issue.
Uh-huh.
Refuses to walk or bear weight on his left leg. So let's just start with that, right?
Yeah.
So in your mind, you should be thinking musculoskeletal mainly, right? Just based on the original. So does he have a fracture? Does he have an injury? What does he have, right? That's after
Yeah.
you see kind of, I'm having a working diagnosis when I read, right? She
Yeah.
says that he has been irritable for the past 3 days, so it's acute, or it could be infected too, something you think about, septic arthritis, something like that. But he has a 3-month history of episodes of moderate pain in his shoulders and ankles. So it's like, oh, okay, so he has some associated pains all over his body, but the pain has not been as severe as his current symptoms. So he does have joint issues in the past, it seems like, but now this is a lot worse. His mother says he bruises easily. Okay, so in your mind, anytime they say bruises easily, it should start triggering, oh, is there a potential of any kind of hemodynamic issues, right?
Yeah.
So thrombocytopenias, right? Hemophilia A and B, right? Especially because it's a boy, right? Something that you're thinking about. That's how I'm starting to think, right? And of
Yeah.
course, von Willebrand's, but mainly they usually test that in females because it's autosomal dominant. He has not had any recent trauma or fever, right? So that rules out any kind of bone breaks, any kind of septic arthritis, right? He was born term with spontaneous vaginal, uncomplicated pregnancy. So no syndromes is kind of what they're trying to say. Walked at the age of 11 months. So you kind of say, he's developing fine. He attends
Yeah.
preschool. He is 70%, 60%, right? So he's on the growth chart, okay, developing fine. Vital signs normal. So once again, not infected, septic, anything like that. There's no gingival bleeding and his teeth are intact. So what that should trigger is like, oh, unlikely it's going to be a thrombocytopenia, right? For the most part, right? There is deep ecchymosis on the anterior aspect of the left thigh, and the skin is otherwise normal. So you should be like, oh, that's major bruising, and why is he having major bruising, right? Patient is
Mhm.
unable to extend the left knee because of pain. Labs are likely to show what? So boy with heme issues, and then joint issues. So you're thinking about heme arthritis and things like that from hemophilia A and B. That's going to be your most likely answer, your most likely differential diagnosis here.
Okay. I
Okay.
just I don't know why I was not associating like joint pain with the heme. I feel like you usually just hear like, oh, they had recurrent nosebleeds as a kid, or they bled after they got their like teeth taken out. Like I didn't really know about the joint pain, I guess. Or
Yeah.
maybe I'd forgotten about it,
Yeah,
probably.
so the key thing about hemophilia A and B, especially in these boys, is a
Yeah.
lot of the times, well, at least I don't see kiddos with hemophilia, of course, right? Not my field, but what you learn on the test. I'm not sure what's the incidence of heme arthrosis, meaning blood that kind of collects around a joint and causes inflammation, right, and causes kind of damage to the joint, is kind of associated with hemophilia A and B, right? So definitely for sure you got to keep that kind of in your mind because they like testing it. So
Okay. And then so platelets would be normal in this?
yeah, so that's the
Okay.
next thing, right? So understanding when you're talking about hemophilia A, that's factor 8. Hemophilia B is factor 9, right? So you got to know, if it's factor 8, then that's going to be which pathway, right? And that's going to be the PTT pathway,
Uh-huh.
right? So that's going to be elevated, but the PT is going to be normal because PT is 1 to let me see, 1 to um 10 and 7, right? Is the main ones, right? Common pathway, but 7 is the main one that deals with prothrombin time, right? But platelets shouldn't be affected, right? Platelets is completely something different, right? So if you're
Yeah.
talking about platelet disorders and things like that, you're thinking about more like immunothrombocytopenia purpura, right? Thrombocytic purpura, right? Or ITB, right? Is usually kind of decreased
Hearing
platelet
that.
counts, or
Yeah.
HUS or TTP, like all these diseases that destroy platelets, or disseminated intravascular coagulation, right? DIC, right? That can kill platelets and things like that. But when you're talking about hemophilia A and B, right, that's going to be kind of factors. Okay,
Okay.
and also something to keep in your mind too is that sometimes they like to test, like for instance, people with you know, characteristics disorders of platelets too, which is different, right? The quality of platelets, even though you can have symptoms of bleeding and things like that, there are some diseases that deal with the quality of platelets, like they can't adhere or aggregate, which is still an issue too, and the platelet count would be normal. So just something to think about. So all these things, when you're reading this question, should be flowing in your head.
Okay. Um, that helps. Yeah. After 16, it was 19.
1 second. It seems like the it's like lagging for some reason. Oh, you said 19, you said?
Yes.
Okay, perfect.
Um, so this is a patient with MS, and she comes in because she has like a 3-day history of like things getting worse. Um, well, actually, I don't know if we have an MS diagnosis yet, but this is our MRI. She's having right-sided weakness, vision changes. Um, and she's had this before, but this time it hasn't like recovered on its own. So they're asking like, what's the most appropriate pharmacotherapy to decrease the recurrence of similar symptoms in this patient? So I guess I was thinking like she's in a flare. We need to treat this. So that's why I said methylprednisolone. But they were looking, I guess, for more like long-term treatment. But I guess how would you know, or like how would you be able to recognize a flare? Because to me, these kind of sound like her symptoms are getting worse. So I would think it was a flare, but yeah, if we could
It's the
just
question. The question asks most appropriate pharmacotherapy to decrease the recurrence of similar symptoms in this patient. They're not asking you, how do you manage the acute symptoms that she has now? They're asking you, how do you prevent these same symptoms in the future?
okay.
So it's understanding the question, I guess, in this sense, right? If they say what is the most appropriate next step in management, then yeah, you want to, that you would treat the acute thing. But their question is most appropriate pharmacotherapy to decrease the recurrence. So like to prevent.
Okay.
So which I actually didn't know this medication actually.
I didn't know it either, but I've learned it now.
Yeah,
So
subcutaneous leteromere. But yeah, so immunomodulator seems like this is something new that I don't
it's
think
like
we've
a
learned this.
DMARD.
Okay.
Okay, next one I have is 20. Okay, this is a like 1-year-old boy. Okay, so this is where I get sometimes I have a hard time determining if this is like a cardiac problem or a pulmonary problem. And I know this should be simple, but I don't know, sometimes in the exam I get things mixed up. And so I was just wondering if we could talk about it.
Sure. I mean, first I would say, right? I mean, chest X-ray shows mild cardiomegaly and hilar infiltrates, right?
Yeah.
So I guess my question is, um, just from that, I mean, I haven't read anything else, but you're thinking likely it's a cardiac issue, right? Because you have a little bit of enlarged heart, right? If it's just bronchiolitis, you're not going to really affect the heart that much, right? Your heart should be normal, just maybe your lungs are hazy, right? But anyways, let's kind of continue here. Most likely diagnosis, right? 1-year-old boy, ER, right? So acute setting, difficulty breathing. So he's having issues breathing. Past 2 days, he had a cough and clear nasal drainage. So anytime you're seeing that, then you're thinking, oh, maybe he had a viral infection, right?
Mhm.
His temperature is a little bit low, right? His pulse, right? 180. I think it's in the higher or a little bit elevated for a kid. Respiratory, he's super tachypnic, right? Blood pressure, fairly low, right? He's anxious, apprehensive. He's cool, pale, and mottled extremities, right? So in your mind, you're already thinking maybe some kind of shock, right? Because you shouldn't be cold, pale, and mottled extremities. So in that case, if you're dealing with shock, then it should not be anything respiratory, like it can't be a primary pulmonary issue, right? Also, they talk about pulses are thready, right? So in your mind, you should already be thinking this is cardiovascular in nature. Scattered wheezes and bilateral crackles are heard on auscultation of the chest, and there is a gallop with no murmur. Okay, so there's a gallop. So this whole picture is they're painting like it's a very cardiac, right? Cardiac issue, right? Liver is also, larger, right? And then they give you a capillary blood gas analysis with O2. So he has a pH that is acidic, right? His body
Yeah.
compensating by breathing really fast. He has less O2. So now they're asking you, what is the most likely diagnosis? So he had a viral infection, then he has shock, right? Because his extremities are cold, things like that. And then he has a gallop on his chest, right? His heart is a little bit elevated, right? The lungs are congested, probably because of backup of fluid. So this has to be some kind of cardiomyopathy here,
Okay.
right? Because
How,
bronchiolitis, right? So that's just inflammation of the bronchioles, right? Of the lungs, right? It's not going to explain to you. It can explain the breathing issues, right? But it's not going to explain the cardiomegaly. It's not going to explain the liver, right? The
yeah,
liver that is swollen up. It's not going to explain, pulses that are thready. It's not going to explain, uh, tachycardia, right? It can explain the tachypnea. But you see what I'm saying? So your answer is only supported by maybe two pieces, but the other 10 pieces are, some kind of cardiac etiology here.
yeah. How do we, I guess, differentiate between the dehydration and the myocarditis?
So the question is dehydration going to cause a mildly enlarged heart?
No,
Is also dehydration, is that going to cause the liver to swell?
no.
Okay. Right, so I would say that the key thing is you got to put the whole picture together, right? For this question in particular, when I'm talking you through it, do you realize how I think you're kind of piecemealing the picture, if that makes sense? You gotta see this kid as as a patient as a whole, if that makes sense, right? So if you saw this kid, you wouldn't think just automatically that it's a respiratory thing, right? Especially if you ordered a chest X-ray and it shows that the heart is enlarged. You can't ignore the heart, right? You know what I'm trying to say? You're ignoring some pieces of information, I think, when you're reading this question.
Yes, sir. Yeah, no, that makes sense.
Yeah.
The next one I have is 24.
Okay. Uh,
Um,
yeah.
Errors.
Errors. I don't know how much I can give you too much for errors. It's a little bit of memorization. I know that doesn't help you much. Um,
Okay.
but type 1 is usually alpha. Type 2, I think, is beta, if I'm not mistaken. Um, or 1 minus alpha, I think. But yeah, I don't know how much I can help except kind of say that this is probably not what's preventing you from, like, this particular question is what I'm trying to say. This particular question is not overall impacting kind of your overall score, I would say. But let me see. I'm trying to think is there any way I can help you remember this?
It's okay. I can just look it up later. I just
Yeah. Yeah,
think,
because even me, I forget this a lot, I would say. But I guess when I know this is probably not the best thing to say as a tutor, but I would say that this is not the highest yield of questions to focus a lot of your energy on.
yeah.
So thinking, looking at those questions that are a little bit more clinical that you can, apply to multiple questions is going to be better than spending a bunch of time on, oh, type 1 error versus type 2, understanding alpha, understanding 1 minus alpha, understanding power, understanding beta, right? Those questions, you might get one out of your test, right? It's not going to be a significant portion of your test. So,
Yeah, no, I agree. To me, these should be easy points. So I was just like learning the different types of studies the other day. That's like, a few easy points here and there. So,
sure.
um, okay, the next one I have is 30.
Okay.
Okay, this is like post-splenectomy. Um, I guess, is there anything I should know about this, like the reactive thrombocytosis? Um, I didn't really know about reactive thrombocytosis
Yeah. This
before
is
this
something that,
question.
yeah, I to be honest, I didn't know much about this either. This is the first time I've seen this question ever, but this is just understanding. Okay, so practically, the way I would template this in my mind so I can remember is like, okay, so it's possible after a splenectomy, right? And if the patient is having a ton, like 1,250,000 platelets, that's like way too many, right? And so probably aspirin. Do you remember kind of what aspirin does by any chance?
It decreases like platelet aggregation.
Yeah, it's going to practically, right, decrease the amount that platelets can like qualitatively work. You get what I'm saying? So if there is a ton of platelets, but they just all don't work, then it doesn't matter if you have a lot of platelets. You get what I'm saying? So it
Yeah,
makes sense in my mind, like, okay, so just give them aspirin. That's pretty easy enough, you know?
yeah, and you just do it temporarily. Yeah, it says the platelets count peak in the 1 to 3 weeks. So then after that, if yeah, okay. I think the next one I had was 41. I might not actually need 41. I might have looked up what I needed on that. Yeah, okay, we're good here.
Okay.
Um, and then 42 is the next one. So I was wondering if we could talk about yeah, like respiratory pulm physiology. So it's like a man with diagnosed HIV, or maybe we suspect HIV. Basically, he has yeah, oh yeah, the silver stain sputum is positive. He has the like pneumocystis jirovecii. Um,
Okay.
and so they're asking like what's the cause of his hypoxemia? And so yeah, I just don't understand
Okay.
the
So let's talk about this. When you talk about alveolar hypoventilation, what does that mean to you?
like the alveoli aren't able to exchange gas
So
efficiently.
that's not. So that's the reason why I want to ask you so that you can kind of verbalize kind of where the misconception is. So alveolar hypoventilation just means that you are not getting air into the alveoli,
Oh,
right?
okay. Yeah.
Like practically, you know, in a grand scheme of things, you're not breathing enough, right? You're not like your respiratory rate is low, so you are hypoventilating.
Okay.
So, AKA, it has nothing to do with the exchange, actually. It's just air coming in and out of the alveoli. Okay. So, when you talk about alveolar hypoventilation, really you're talking about things that suppress the respiratory rate. So, opioids, alter mental status, right? Sometimes, if, barbiturates, right? Things that practically, affect the brain enough to not breathe. You know what I'm trying to say?
Okay.
So that can't be this guy, right? It doesn't say he's on opioids, he's not on drugs, he's not altered, right? Anything like that. So it cannot be alveolar hyperventilation.
Yeah. No. Now that I know that definition, it makes sense.
Okay. So let's talk about AV shunting,
Uh-huh.
right? What is AV shunting? Arteriovenous shunting.
It's where it would be like, I guess if you have a heart defect where like potentially where oxygenated blood is mixing with deoxygenated blood.
Good, good. So a lot of the times, if you have arterial venous shunting, right, that like you said, it's from the arterial side into the venous side, and it just means that you know you, in a sense, when you have the mixing of blood, it can return faster. You might have more preload, right? Things like that can happen, right? And so this in particular has nothing to do with that. So you don't have to worry too much about that. So atelectasis, talk to me about atelectasis.
That's when uh like maybe you are giving them too much via into like oxygen via intubation, and not all like some of their alveoli collapse, I think.
Um, so actually, positive pressure ventilation actually opens up alveoli. So it's actually the opposite. So actually, atelectasis happens when patients are not breathing very well after surgery or sitting there for a long time bedbound and they're not taking deep breaths. So the alveoli will collapse and cause atelectasis. Okay. But remember, when you are intubating someone, you giving them pressured breaths, you're actually pushing air like with pressure. And so it helps inflate the alveoli. Does it make
So
sense the difference?
intubation is preventing atelectasis
Um,
if it's on the right settings, I guess.
yeah, I mean, what I'm trying to say is don't associate intubation with atelectasis. That's not how you should think about it. Okay, because positive in expiratory pressure or PEEP, right,
Yeah.
or or CPAP, right, to continuous positive airway pressure, right, that allows you to push air into it, which inflate. It's like a balloon, right? So you can inflate it. So, but atelectasis is a collapse of the balloon. You get what I'm saying? So
Okay.
when you're on the ventilator, you really shouldn't have atelectasis, but the ventilator can cause you to have rupture of it and cause you to have a pneumothorax, which is something completely different, right? But atelectasis is just collapse of the alveolar spaces. So, like I said, if you're bedbound, you're not taking deep breaths, and which is why in the hospital we give them insinus spirometry, right? We
To get
force
them
them
to
to
kind
take
of,
big
yeah.
deep breaths to inflate their alveoli to prevent pneumonia and atelectasis.
Okay.
Does it make sense?
Yes, sir.
Perfect. Okay. Decreased dead space ventilation. What is dead space ventilation? Talk to me what dead space is.
It's usually the top of your lungs where air exchange isn't as efficient, maybe.
Um okay, so the definition of dead space, okay? So understanding these definitions is super important. So dead space is an area where air and blood, right? There's no air blood exchange, right? Oxygen does not diffuse into the bloodstream. That is what's considered dead space. So, in particular, in the human body, right? In the human body, the places that are dead space, that are natural dead spaces, are your trachea, your bronchi, and I think it goes all the way to your bronchioles or bronchioli, right? Up until the alveolus and respiratory bronchioles, right? Because those deal with air exchange. So everything above that tree doesn't deal with air exchange, which is dead space.
Okay.
So decreasing dead space ventilation, I don't even know exactly what that means because if anything, that helps, right? I mean, but I don't know how you would decrease dead space, right? Your trachea can't diffuse any more gas or anything like that. So I'm not sure exactly, what they mean. That answer doesn't actually make any sense. So decreased diffusion capacity. That answer is exactly what you described to me for alveolar hypoventilation. That was incorrect. It deals with how much air is exchanged from the alveoli into the blood, right? There's a diffusion barrier, right, which is usually like one cell length and length to be able to diffuse from the alveoli into the bloodstream and exchange oxygen for CO2 naturally, right? But if you have pneumonia or pus in the alveoli, then that's going to cause inflammation, damage, right? And a barrier, right? So if I were to draw this, right, I always kind of draw, if you imagine here's the alveoli, right? And then you have the blood that kind of flows, right? And so this exchange happens, between kind of this layer, right? And so oxygen goes one way, CO2 goes the other way, right? So if you have pus in the way, just imagine there's a layer of pus that the oxygen and has to be able to diffuse against, right? Or inflammation. So that's going to inhibit you from oxygenating very well. Does it make sense?
Yes. Yeah, that makes sense. And that's exactly what I thought alveolar hypoventilation was. But
Yeah.
now, yeah, I have a better understanding.
All right. Perfect.
Um, 42, is that what this was? Okay, the next one I have is 25 in section 2.
Okay.
Do you want to talk about this or do you think I should just try to do it
No,
on?
this one you can clinically, it's not horrible. So talk to me kind of, how do you interpret this? What were you thinking? Kind of reading all this.
Honestly, I just guessed. I didn't know. And I was like, I'd rather spend my time trying to get other questions correct.
Sure.
So,
Sure. So So talk to me. What do you know about relative risk? What does that clinically mean?
Um, it's like if you have whatever variable they're looking at, how much it increases your risk from baseline to develop whatever disease or uh, outcome they're looking at.
Okay, good. And it's usually a ratio, right? Or a fraction, right? So in this particular trial, they're practically seeing, right, a new drug probably versus an old drug, right? Causing the risk for cancer development, right? Or compared to placebo, some kind of comparison here. But anyway, so then right, they have 6 studies, okay, and these are box plots, right?
Uh-huh.
Okay. So understand box plot is super important too, right? So, from here to here's the range, right? Here's the one lower extremity, the other is the highest extremity. I believe the dot is the mean, right? And usually there's some extra, there's a box too with whiskers too that can split it up into quartiles also. But here, you just have the mean and the range, right? So now, right, they go the result of the meta-analysis. Meta-analysis mean they aggregate 6 studies and then have data from the 6 studies and make a conclusion, or conclusions with an S, based on
Mm.
those studies. So now they say which of the conclusions can be drawn from this data. So remember, I told you it's a ratio, right?
Yeah,
Okay, it's a ratio or fraction. So if you have one variable divided by another variable that are exactly the same, what will they equal?
one.
1. So you know that a relative risk of 1 means that there's no higher or greater risk. There's no, you know what I mean? There's no difference in risk. You get what I'm saying? So if you
Yes.
take a look, this is actually a fairly not too difficult, right? So here's the 1 marker, right? So when they aggregate it, right, the mean and also the extremities sit in this range right here, which is less than 1. If it's less than 1, then actually the drug significantly decreases cancer risk because it's less than 1. Does it make sense?
Okay.
That's all.
It
But
was
now
greater than one, it'd be
say it again.
increased risk.
Say it again.
Greater than one would be an increased risk.
Yes, but here's the caveat I went to. So if the diamond and let's say the diamond is somewhere here,
Uh-huh.
right, with kind of the extremities here, then you could say D is the right answer. But now my question is, what happens if the diamond is here, right? But hold on, I'm trying to say, I guess if the standard deviation, I guess it's hard because I don't think they will test you on something. But just remember this: if the standard deviation within kind of the brackets that they give you, let's say in numeric, contains 1, that means that there is no, there's no association, right? Like there's no, like if it includes 1, then you know that there's no increase or decrease. Does it make sense? So if
Okay.
the diamond sits right here, right, even though it's skewed, right, but it includes 1, you see that it includes 1, then you know that there's no association.
Is that only the diamond or is that also the
The
whiskers?
whiskers, yeah. So that's where it gets a little interesting because usually they test you with the standard deviation. So that's why I wasn't 100% sure. That's why I didn't want to tell you. So you might want to look that up if the whisker includes it. I want to say if the whisker does include it, then it might not be significant, but I could be incorrect. So um,
Okay.
but I don't think I've ever seen that question, but I guess it could be. But just know that if it includes 1, then it's not clinically significant, or there's no association because 1 is included, right? So
Less risk. Okay. Um, and you can stop me at any point. The next one I have is 29.
okay.
Okay, these are like our hemoglobinopathies, but I think this patient actually has sickle cell. Um,
Okay. So if you said the patient has did you know the patient has sickle cell?
um, I don't think they tell us specifically, but
Well, I
for,
mean, when you were taking the test, did you know that the patient had sickle cell?
oh, yes, I just don't know the concentrations or like the what's absent. Is this
Okay.
just memorization, or is that what you would say?
Well,
Or
I mean, first, okay, so Ali, I just want to kind of take a step back here, okay? So because I think that what's going on is with some of these questions, right? It's not the fact that you missed it, right? It's the fact of what you chose is kind of why I want to stop and kind of, if you knew the diagnosis was sickle cell, right?
Uh-huh.
Then why did you say decrease hemoglobin S concentration, S for sickle cell?
Um,
You know what I mean?
yeah, no, I just like chose one. I don't
Oh,
know.
okay.
Like don't know these very well, so
Okay.
I
So my only caveat to that is that I want you to kind of, when you're taking these tests, right? Even if you don't know, right?
yeah.
I want you to be purposeful with your answer choice, right? Because when what I mean by that is this, right? If you told me, oh, I didn't know what it was, but I chose anything but D because S is usually for sickle cell, then that would mean, okay, that's okay for me, right? But if you choose D and you told me you completely randomly chose, this means that you read the question, you knew a sickle cell, you read these, and were like, kind of like, I kind of give up. You understand the difference what I'm trying to say?
Yeah, I honestly didn't think about S standing for sickle cell. I don't know what I
Okay.
was thinking. So,
Okay. So that's, I mean, you know, I guess my thing is kind of, just I, I'm trying to say it like in a sense of like on a test taking strategy, right? I want you to, even if you don't know and you don't have a start place here, right? I like, because it seems like you're finding the diagnosis, right? But I want you to at least sit there and be like, test taking strategies wise, what could S mean? Right? Even if you don't remember that factoid, right? Because I want you to kind of make in a sense, educated guess, not a complete guess, if that makes sense. Okay.
yeah. Yeah.
All right. But yeah, so kind of answering your question on a roundabout way, right? So, 3-year-old African American boy, right? 3-day history, right? You see a little bit of sickling, right? And African American, so increased incidence in African Americans, right? So, anemia, right? Hematocrit, blood smear, right? Shows sickling, right? So with sickling, right, you're gonna have an increase of hemoglobin S, right? Which is the sickle, right? For the S, right? And so that S is kind of replacing hemoglobin A, right? And so you're going to have an absence of hemoglobin A. Absence of hemoglobin F is not right. It's actually going to be slightly increased because your body is going to try to use a different subunit because it doesn't have A. Decrease in hemoglobin C concentration. You shouldn't have any hemoglobin C usually in the sickle cell. It's going to be increase in hemoglobin S for the sickling, right? And then normal hemoglobin A concentration, right, is not going to be right because it's going to absent. Also, on top of that, on a test taking, right, after reading this, right, usually if you're reading this and there's two opposite answers of the same thing, then you can at least get it 50-50.
Okay.
You know what I mean? Like, that's why I'm trying to say, like, on a testing standpoint, right? There are better ways to answer than a complete, oh, I didn't know, right? Because you should be thinking, oh, why would they have a normal hemoglobin A answer and an absent hemoglobin A answer, right? So that should be in your mind, like, okay, maybe I don't know, at all, but at least I can like go 50-50, right, on a guess instead of, you've increased your odds to 50% versus 20%, right? So you've in on a math term, you've 2.5 times your chance of getting it right. So yeah, just things like that, small things.
Um, yeah, that makes, I mean, that makes sense now. I don't know what I was thinking during the exam.
No, that's all good. I'm just trying to give you tips and pointers, because we all take, we all take these exams, and you know, you're always going to get a question that you don't remember or you don't know. But you have to kind of use what's in your arsenal to give you the best chance of getting it right. If you don't know the information, then at least you can play the game of test taking, if that makes sense, right? So, but if you kind of just say, "Oh, I don't know," and then just say 20%, then in a sense, right, you haven't used your test taking strategies. You know what I mean? So,
Yes, yes, sir. Um, the next one I have is 30.
okay. So,
Um,
Yeah.
I
What do
was
you think diagnosis is for this patient?
this was an 11-month-old who's like a pretty acute, like 2 hour history of cough and difficulty breathing. He's been irritable since then. Um, the only thing is he also has he's like febrile. So originally I was thinking just like the timing wise of things, like maybe he uh like foreign object because it's like he's been irritable and has little to eat or drink since the onset of symptoms, which was like 2 hours ago. Um, and he has like a deep cough. So I was thinking maybe he just put something in his mouth. But
But how about like I guess my so this is going back to kind of what we talked about a little bit before, but how about the fever?
yeah, I mean, I don't really know how to explain that.
Yeah. So I guess this is just going back. Is that I want you to really think about kind of the overall clinical picture, right? Like as in, I like where you're thinking. It should definitely be in your differential diagnosis. Okay, is a airway foreign body. I think that's great, right? 11-month-old, right? Pediatric kid, acute issue, cough and difficult breathing for 2 hours. So right from there, I'm like, okay, yeah, for sure, that can possibly be. Maybe they, swallowed a penny or something like that, right? Then mother has been irritable and little to eat or drink since onset can still fit with your differential, right? And then is agitated, difficult exam, still kind of fits with that airway foreign body. But then deep barking cough, okay, which can be a airway foreign body, but when you hear this physical exam, you should also be thinking, oh, it could be croup, right? Because they always call it a barking cough, right? It's kind of how they describe it, and
Yeah.
or seal like bark, right? And then a temperature of a 101.3, right? So anytime you have a fever on a test, you should be thinking infectious of nature until proven otherwise, right? That's just on a vital standpoint on a test, right? Got to be thinking infectious in nature unless proven otherwise, right? And then there's a mild inspiratory stridor is heard, right? Which fits with croup best here because it's an infection. You have stridor, you can have difficulty breathing, you have a cough, it's acute, right? And now the question is, right, what do you do next if it's croup, right? And then you can do, inhaled cool mist, humidified air that can help with the inflammation and things like that. And of course, if kid needs oxygen, can give supplemental oxygen, right? But direct laryngoscopy is unlikely needed for croup. It's in the subglottic space, right? You get a steeple sign and things like that. So, but does it make sense kind of how it worked through that?
Yeah. I mean, I think I did similar up until like cough and febrile. So I just need to make sure I'm taking everything into account.
Yeah, yeah.